Well, let me welcome everyone for coming to our second annual School of Medicine Festival of Science. This is a very special day that we've set aside, and it's so good to see so many of you across the campus, across the School of Medicine and elsewhere, joining in to celebrate the festival with us this morning. As you know, the theme for this event is infections, inflammation, and vaccines. And clearly this title seems very fitting considering the current health concerns around the world and here in the United States. We're honored to have several distinguished guests and individuals who are here in our midst. And if you can indulge me for a moment while I just recognize a few of those special guests. By the way, I should make mention that our board chairman sends his regrets. He was able to be with us yesterday, Michael Cryer, but is unable to be here this morning and sends his regrets. I'd like to recognize my healthcare partner and colleague, Bob Krenzik, at the front, President and CEO of the University of Maryland Medical System, Dr. Jane Kirschling, Dean of the University of Maryland School of Nursing, and I'd also like to recognize a good colleague and friend, Dr. Mort Rappaport, who is a former President and CEO of the University of Maryland Medical System. He's here with his wife, Rosalie, and daughter-in-law, Deborah. I will comment on our guest, our keynote speaker, in a moment. There are several other distinguished guests in the audience, but I want to just welcome you very much for coming. This is a particularly exciting time. I'll recognize at this time in general our Scientific Advisory Council members who are here. In a moment I'll recognize them in greater detail, but as you know, they have been here last year, spent time from their busy schedules to be with us, so we're very happy that you're here. The Festival of Science is the cornerstone of the School of Medicine's accelerating innovation, discovery in medicine, or as many of you will hear the term, AccelMed. AccelMed embodies the research components of our shared Vision 2020. Vision 2020 was established in conjunction with the hospital partners led by President Robert Krenzik. Key elements of Vision 2020 includes the following: maximizing our expertise and resources, fostering a culture of high-intensity, multidisciplinary science. Third, adopting a new teaching philosophy in how we train the next generation of outstanding physicians, scientists, and allied health professionals. And fourth, enhancing our acclaimed excellence in high-quality, patient-centered care. As a research component of Vision 2020, AccelMed initiative is aimed at significantly and measurably increasing the pace and the scope of discovery and innovation, with the ultimate goal to dramatically improve human health and well-being. In order to maintain and indeed attain this ambitious trajectory, last year we established our External Scientific Advisory Council. This council provides us with critical advice on our research portfolio, our programs, and our plans. It does so during our annual Festival of Science Day, which today obviously is. We're very fortunate to have recruited 5 of our nation's preeminent scientists to join the inaugural council and to participate in the festival for a 3-year renewable term. While each of these council members will have their full biographies in your program booklets, let me briefly introduce our esteemed council members briefly at this time. First, in no order at all, Dr. Rita Caldwell is the chair of Canon U.S. Life Sciences, Inc., a distinguished university professor at both the University of Maryland College Park and the Johns Hopkins University Bloomberg School. Thank you so much, Dr. Caldwell. Next, Dr. Carol Ryder is the Daniel Nathans Professor and Director of the Department of Molecular Biology and Genetics at the Institute of Basic Biomedical Sciences at the Johns Hopkins University School of Medicine. In 2009, Dr. Grider was awarded the Nobel Prize in Physiology or Medicine. Thank you very much, Dr. Grider. Next, Dr. Philip Needleman. Dr. Needleman is a distinguished alumnus of the University of Maryland School of Medicine and of the Department of Pharmacology. Dr. Needleman served as a former professor and chair of the Department of Pharmacology at Washington University in St. Louis, Missouri, subsequently serving as president of Research and Discovery at Searle Pharmaceutical Company. Dr. Needleman, thank you so much for your service. And finally, for today, not finally in our total council members, but for today, Dr. Ralph Snyderman is the Chancellor Emeritus of Duke University and the James B. Duke Professor of Medicine. He currently is the chair of the University of Maryland School of Medicine's Scientific Advisory Council. Now, we have a fifth member who was unable to be with us today, but I will just recognize him as well. Dr. Elias Zerhouni, who is currently the President of Global Research and Development at Sanofi Pharmaceutical and the former Director of the National Institutes of Health. Dr. Zerhouni sends his regrets since he's not able to be with us today. In fact, I just want to read a brief note that Dr. Zerhouni has asked me to share with you. He said, due to a previous commitment, I'm unable to attend this year's festival. I truly regret not being with you to share the talks and the interaction of this year's interesting theme. I'm confident it'll be a great day of science and discovery for all, and I wish you full success. I look forward to seeing you at next year's festival. So we're so delighted to have our wonderful council members. So ladies and gentlemen, please join me in a round of applause for our council members. We have a full day of science planned. So let me briefly explain the agenda. After a keynote address this morning, we'll hear from our presenters whose presentations will be divided into those focused in infections and vaccines this morning, and in the afternoon will be focused on inflammation. Following each presentation, if time allows, there will be a brief question and answer period. However, following all the presentations in the session, there will be a question and answer period during which the council members will have an opportunity to speak directly with the presenters, and if time permits, the audience will participate. Now, it's not by chance that we invited one of our nation's preeminent public health leaders and staunch advocates for the biomedical research in general. And that person is none other than Dr. Tony Fauci. Dr. Tony Fauci will give today's keynote address. And let me make a commentary. Dr. Tony Fauci was keyed up to be here this morning, was planned to be here. Yesterday late afternoon, he sent me an email indicating that President Obama has called an emergency meeting this morning for leaders with the Ebola crisis, and he needs to be in the White House this morning with all the leaders. But he has arranged to make his presentation directly through in a video feed. So we're very, very delighted that he was able to arrange this and at the same time maintain his commitment and appoint with the president. Now, obviously, I wasn't in any competition with the president, so I conceded that that was a very reasonable adjustment that he could make in his schedule. Now, Dr. Fauci's biography is detailed in the program booklet, but I'd like to just give a brief and abbreviated introduction of his extraordinary career and accomplishments. Just briefly. Dr. Fauci is now in his 30th year as director of the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health, where he oversees an extensive research portfolio of basic and applied research. There's almost no disease or condition that the NIAID does not support, from infectious diseases such as HIV/AIDS, malaria, tuberculosis, immune-related illnesses such as autoimmune disorders, asthma, allergy, transplantation, bioterrorism, and radiation and radiation nuclear countermeasures. So essentially, the NIAID covers nearly all of the major areas in our discipline. Dr. Fauci is probably most well known for his seminal contributions to the understanding of how HIV destroys the body's defense, leading to its susceptibility to deadly infections. He is one of the principal architects of the President's Emergency Plan for AIDS Relief, known as PEPFAR. This has already been responsible for saving millions of lives throughout the developing world. More recently, Dr. Fauci has been a spokesperson for the nation's fight to treat and prevent pandemic influenza, SARS coronavirus, and most recently, the Ebola virus disease outbreak in West Africa. Dr. Fauci is a member of the National Academy of Sciences, the American Academy of Arts and Sciences, the Institute of Medicine of the National Academy of Sciences, and the American Philosophical Society, as well as a myriad of other professional societies. Dr. Fauci has delivered major lectures all over the world and is the recipient of numerous prestigious awards, including the United States Presidential Medal of Freedom, the National Medal of Science, and several other national awards. Dr. Fauci has been awarded 38 honorary doctoral degrees from universities in the United States and abroad. Ladies and gentlemen, please join me in welcoming to the electronic podium our keynote speaker, a good friend and a colleague, Dr. Tony Fauci.
Thank you very much, Dr. Reese. It's really a great pleasure to be with you this morning, albeit by video. I want to first thank you, particularly Al, for your indulgence in allowing me to appear before you by video. As Al mentioned quite correctly, literally yesterday afternoon, the President decided that he needed to have a meeting to regroup and relook at what's going on, both in West Africa and the potential in the United States, and called a meeting of all the players in the Roosevelt Room a few hours from now, and I just could not get from Baltimore back down here. So I really appreciate your indulgence in allowing me to do this by video. And now, don't undersell yourself. It was a close call between you. Let me get started. As you can see from the first slide, the topic is Ebola, and I use the title The Perfect Storm, and I hope that will become evident to you why I chose that in a moment. I'm going to divide my talk into 4 components listed on this slide. First, a bit about Ebola background. I know this audience is sophisticated enough to know that, but let me just quickly review it for you. First, the virology. It's a filovirus. If you look in the lower right-hand side of the slide, you'll see why it's called a filovirus, because of the filament-like particles in green surrounding the viro cell in blue. It is a rather ugly virus when you look at it in an electron micrograph compared to other more defined-looking virions that you see. It matches the extraordinary destruction that it causes. There are 5 species involved, each of which have been tagged with a variable mortality. The one that we're dealing with now is the most virulent, namely the Zaire strain. But what we're starting to see as we get the opportunity in the United States to treat people, that perhaps the mortality isn't just linearly related to the virulence, but maybe associated with the ability to treat people in an intensive care way, and we'll get back to that in a moment. The transmission cycle in humans, at least, is well established. I'll get to that in a moment. It is an enzootic cycle disease, as in most emerging infections, 75% of which emerge from animals that are called epizootics. They are zoonotic diseases. We know that it exists in the fruit bat. We know that non-human primates have kill-offs as well as certain antelopes. However, despite this knowledge, It is really unclear about the transmissibility and the cycle enzootically. Once it gets into a human, we know very clearly how it is spread from human to human. But we should remember that this is not fundamentally a human virus. When an outbreak is suppressed, we do not see continual endemic involvement in humans. It is characterized by individual outbreaks. The transmission routes are shown on this slide. I mentioned infected animals are the source in which it jumps to the human species. But once in human, it's contact directly with bodily fluids. We've heard a lot about that from the experience in West Africa, including blood, vomitus, diarrhea, feces, and even sputum in the late stage when the virus gets into the lung. It can live on fomites, particularly if there's proteinaceous material, on clothes, on personal protective equipment, blood, feces, vomitus. The virus can stay and live there for a day or more, several days in fact, which is one of the reasons why in funerals and cleansing the bodies is a major form of transmission. The typical clinical course is now well established with an incubation period ranging from 2 to 21 days. If a person gets exposed, although the range is 2 to 21 days, it really clusters very heavily around 8 to 10 days. In fact, it is a distribution curve that's very heavily weighted towards that middle, even though there are outliers at 2 and up to 21 and very rarely more than that. After a couple of days of being clearly infected, a person has about 3 days of a flu-like syndrome of weakness, usually not vomiting yet or secreting or excreting bodily fluids that can transmit. However, by about day 4 to 7, there's vomiting, diarrhea, hypertension, and then multi-system failure, which is predominantly, although not exclusively, due to hypovolemic shock. And we're learning that now as we have so many patients in West Africa and there's several that we've had the opportunity to take care of here in the United States. And by multi-system, I mean kidney failure, congestive heart failure, liver failure, and very rarely bleeding. The stories you hear about it is people bleeding. Less than a couple of % of individuals actually bleed. Most of them die from hypovolemic shock. One of the people in my group, Dan Chertow, and we have several volunteers from our group here at the NIAID and hospitals in West Africa. Dan Chertow just recently wrote a report in the New England Journal of Medicine in which he describes his experience with over 700 people working with Médecins Sans Frontières in August and October. And the description of the symptoms and all of the other aspects match very, very well with the original 1976 report and a very well-documented report in 1999 of the 1995 Kitwick epidemic. Of particular note, and this has to do with the scare that we have gone through in this country about whether or not a person who's mildly symptomatic, namely emit QH but isn't yet vomiting or getting diarrhea or anything like that, none of the cases on the lower bullet were patients contracted Ebola from someone during the early febrile illness. And that's the reason why it's pretty confident, though you never say 100%, that if a person, 90+% who are infected, wind up getting fever, if you're without a fever and without symptoms, it is extraordinarily unlikely that you will transmit the virus to another person, which is the basis of our evidence-based policies about monitoring people and restrictions of people, and I'll get back to that in a moment. Let's go now to the current outbreak in West Africa. It started off with a single case of a child in Guinea in December of 2013. It went relatively undetected. There was many little outbreaks around a funeral, thought to possibly be cholera, possibly be Lassa. But then what happened after a few months of smoldering, there was a multiple outbreak from Guinea to Sierra Leone and Liberia. The thing I was impressed with, having been to Africa multiple times, was that the geography shows that Guinea is wrapping itself around Liberia and Sierra Leone, and that's the kind of borders that we see and hear about. And I'm going to march through with you some slides very, very carefully. Just a second. Raise my voice up. Okay, sorry. I was just signaling from my man. I thought I was talking pretty loudly, but I'll do it a little bit more. Okay, so as you can see, there's a geographic perfect storm where you have now, as I march through these slides, this is May. I want you to look both at the red color and at the right-hand side of the slide, which gives you the confirmed and suspected cases. As we go from May to July to September, as you can see now, Liberia is taking over as the major epicenter. As you go to October, Sierra Leone is catching up. As you go to November, we still have an extraordinary number of cases. And as the most recent, as of literally today, we now see about 18,000 cases, close to 7,000 deaths. And Sierra Leone is now taken over with regard to the most cases. This is now, as I'm going to show you on the next slide, truly historic. And the reason I say that is that we've known about Ebola since 1976. There have been about 24 outbreaks since then, all of which have been in relatively remote areas of Central Africa. And so the containment philosophy and strategy of identification, isolation, and contact tracing worked relatively well. However, what we have here now is a number of cases, and I couldn't plot every outbreak with a red dot or a white circle because not every one of them was large enough to even fit on the slide in a proportional way. Nonetheless, you can see that the cumulative total of cases of the 24 outbreaks was 2,400 cases and 1,200 deaths, which means that the current outbreak is in fact several-fold larger than all of those combined. So how did that happen? What were the factors that allowed that to happen? And that's what we're seeing on this slide. Because in an unprecedented way, we were dealing with poor nations with truly limited health infrastructure. I was not fully appreciated what limited health infrastructure means until I dealt with the numbers. There are about 1 to 2 doctors per 100,000 people in this region. I just cannot help but think that I live in Washington and on K Street downtown, in one floor of one building on 21st Street across from GW, there are more doctors than in 3 countries in West Africa. And that's just the truth. West Africa has had no prior experience with Ebola. As I mentioned, few health professionals. The borders were established by colonialism. There are tribal connections across the borders, so they're very porous. People go from one country to another to trade, to work, and to live. There is limited cooperation among the governments, and as we all know, there's a history of terrible regional conflicts, including recent civil wars. And importantly, the burial practices, the local customs, again, something I didn't fully appreciate. The nations there are those of very warm physical contact, affection that's shown in a custom and traditional way. And when someone dies, there's a days-long dealing with preparing the bodies, hugging, touching, and kissing, which turns out to be one of the most flagrant ways that the virus is transmitted. Now a little bit about the virus. There has been considerable discussion that I have to deal with about the fact that the virus indeed mutates. This is no surprise, I'm sure, to this audience. It's an RNA virus. RNA viruses mutate frequently because of their lack of a good proofreading mechanism. Most of the mutations are synonymous. Namely, there's no evident functional change. Some rarely are non-synonymous, but there has been no significant evidence of major functional change. Nonetheless, as soon as it was reported that there is mutations, we had the first of a series of somewhat, I would say, exaggerated at best and perhaps hysterical at worst concerns of what might happen. And this is just one of the headlines from CNN. Namely, Ebola in the air. Namely, is it truly airborne like influenza? I had to go through many discussions, even at the last 7 congressional hearings or briefings that I went to, and what I kept saying, which is the truth, you never say never and you never say always in biology, but in fact, even though it is mutating, there are no real examples historically of a virus that has completely changed its method of transmissibility by mutation. We know it gets a little bit more virulent, maybe, perhaps a little bit less virulent, perhaps a little bit more efficient, but to completely change its method is essentially unprecedented. Also, if you look back historically at the original papers, even in household contacts, there were no transmissions for those who did not have direct contact with the patient. So if a patient lived in a home, people using the same bathrooms, using the same tables, using the same utensils, there were no transmission except for direct contact. So what has the response been in other countries and here? And that is education, hygienic practices, importantly contact tracing, the use of proper personal protective equipment, prompt isolation, and importantly, as we've seen recently in Liberia, safe burials. The President of the United States has responded briskly and abruptly with a considerable amount of resources. The U.S. military is now putting up Ebola treatment units. We have a 25-bed facility for healthcare workers. The NIH is involved now with making preparations that I'll get to in a moment for vaccine trials. And the CDC and USAID has given unprecedented support in numbers of people who are on the ground, literally, as we speak. I want to move now to another very interesting aspect of all of this. Ebola in the United States. And this can best be described, as we've said, where in the United States, fear seems to have spread faster than Ebola. And I'll explain what I mean in a moment, and I think everyone is aware of this. The confusion is, when people think of Ebola in the United States, they immediately look at the media, television, the print media, and make an extrapolation that's understandable, but frankly quite inappropriate, of seeing the dead bodies on the streets of Monrovia and Freetown, seeing the people dying at a high rate, and immediately say that's what happens in the United States if we get a case of Ebola in the United States. When in fact it's very important to break down the Ebola in the United States into 3 separate buckets. Namely, deliberately air evacuating someone under controlled conditions, such as the patient shown on the first bullet. And I'll get to it in a moment, but just yesterday afternoon, I admitted someone with an exposure right here to the NIH who was exposed in Sierra Leone. And we're observing this nurse now to see if she's infected. Others are already known to be infected, like Ken Brantley and Nancy Rifle and others. The next is an inadvertent importation of someone infected in West Africa who got through screening but only had manifestations when they got here. And that is the now famous Thomas Duncan in Dallas, who I'll get back to in a moment, and Craig Spencer, the healthcare worker who went to New York and was ultimately admitted to Bellevue. And then there's the unfortunate cases of healthcare workers who were infected in Dallas taking care of Mr. Duncan, namely Nina Pham and Amber Vincent, and I'll get back to them in a moment. The United States is not the only country that's doing air evacuations. This map shows the several other countries that have evacuated their healthcare workers to their countries to be taken care of. The two most famous, as it were Kent Brantley and Nancy Leipold, who started off this now process of evacuating our own healthcare workers to the United States. They were evacuated to Emory and did quite well. There are several additional medevac cases shown on this slide. As I mentioned, the centers that have been trained now are several, but the three that have trained for years are Emory, the University of Nebraska, and NIH, and more on that in a moment. I want to spend a minute or so on this inadvertent importation of Ebola, because this is what the Congress and other leaders are concerned about, what impact this would have in the United States. You know the story because it was well characterized. Mr. Duncan left Monrovia on the 19th, arrived in Brussels on the 20th, then went from Brussels to Dallas on the 20th of September, was asymptomatic on the plane and for at least 4 days in Dallas. We know now retrospectively that what we said, that an asymptomatic person doesn't transmit, is very, very true. Again, maybe never 100%, but clearly it's not happening. He developed symptoms on the 24th, went to the emergency room on the 26th, was seen but not admitted, went back to his apartment on the 28th, on the 26th, and for 2 days was in contact with his family. Again, did not transmit. On the 28th, was taken by ambulance to the Dallas Presbyterian, tested positive on the 30th, and died on the 8th of October. However, this triggered something that created a great furor in the United States, and that is 2 nurses who took care of him got infected. We had the opportunity at the NIH of taking care of Nina Pham. This is a picture of the NIH Clinical Center. Those of you who've been there, and I know there are many in the audience who recognize it, what you likely won't recognize on the left-hand part of the slide is me in my latest Brooks Brothers suit. We had a train, and we've trained for years about donning and doffing safely and taking care of the ill patient. And that's what we did for the 8 days that myself and my team took care of Nina Pham at the NIH Clinical Center. Happily, it was a good result. This is a picture of Nina in where we discharged her in front of the NIH Clinical Center on the left-hand side, and on the right is Nina with a team of our nurses who took care of her during her 8 days of illness there, and she's now doing very well, recovering with her mother in Fort Worth. Now, that led to a number of issues that I want to briefly discuss, because it was brought up that perhaps we should ban all air travel from West Africa. You've heard the arguments that I and Tom Friedman and others have made about how that would be counterproductive, because it would close off a countries, plural, that would need our assistance as well as the assistance from the rest of the world. So what happened is that airport exit screening, shown on the left slide, together with entry screening at 5 airports, so that if a person has fever, symptoms, history of contact, they either do not get on the plane, or when they land at one of the 5 U.S. airports, they're double checked before they're allowed to go out into society. If you look at the numbers, it shows you that there aren't lots of people who are infected trying to get into the United States. This MMWR that came out 3 days ago shows that when you look at exit screening from the West African countries, there were 80,000 people screened in the 3 countries. 12,000 wanted to come to the United States. Of those who were denied boarding, none had Ebola. Most had malaria. If you look at the U.S. end, when people arrived here, almost 2,000 people were screened for Ebola. None had symptoms on the plane. 86 were referred to the quarantine officer at the airport. 7 of 86 were found to be symptomatic and had further medical evaluation, and none had Ebola. Most had malaria. And so really, Duncan was somewhat of a real outlier. And it was for that reason why we feel it is not prudent to completely block any travel back and forth to those countries. But there's another issue. What about our healthcare workers? This is Craig Spencer. You remember him now as the most famous bowling doctor in New York. The man who did exactly what he should have done. He's a brave person, was infected in West Africa, came here, walked around, did his thing. As soon as he got a fever, he reported it, was admitted to Bellevue, and no one got infected. However, that triggered a movement to quarantine our medical workers, which, as many of you know who've seen me in the media, I have said there's no scientific basis for doing that because people misinterpret isolation of a sick person who truly has a disease from quarantine of a person who's exposed but not ill. We didn't want to quarantine our healthcare workers because we wanted to balance the risk to the American public, to not only the rights of the healthcare workers, but the unintended consequence of tying up all of our healthcare workers for 21 days, which would not only be a disincentive, we would run out of healthcare workers very quickly who were willing to go to West Africa. And so what we did, Tom Frieden and I, the CDC, and the NIAID got together and did a stratification of risks, namely high, some, low, none. And you see it on the slide. I don't want to go through all of it, but on obviously high risk is a needle stick, like the individual who we've actually just brought into our hospital, or taking care of a person without proper PPE. Then there's some risk, close contact. When we took care of Nina Farm, all of us were considered low risk, but we still had what's called direct active monitoring. And I'll explain that on this slide. So instead of blanket quarantine of healthcare workers, you stratify their risk. If they have a high risk, you directly actively monitor. Namely, someone else takes your temperature, records it, and does a symptom history on you every day for 21 days. And your movement is restricted. If you have some risk, you still get monitored, but a case-by-case basis restricts your activity. Low risk, like I was, because I used the proper protective equipment, I still had to have somebody take my temperature every day for 21 days, but my travel was not restricted. And we feel this is the prudent way to go. So let me close on the last few minutes on the role of research and development in diagnostic vaccines and therapeutics. With diagnostics, there are 2 approaches. One, a diagnostic that's point of care, namely that you can make the diagnosis in 20 to 60 minutes, 20 to 40 minutes. The other is a more sensitive diagnosis where you can make it even when the viral load is extraordinarily low. But let's concentrate on vaccines first. As we know, because it's been well publicized, there are about 5 vaccines in the pipeline. 2 are being very actively pursued. The first is one developed at the NIH's Vaccine Research Center at NIAID. It's a chimp adenovirus with an insert of a Ebola glycoprotein gene. We did phase 1 studies at NIH. The monkey data looked, the chimp data looked very good, protecting these. This was in rhesus macaques with the chimp adenovirus. It looked good. It was recently published in October in Nature Medicine. We started the phase 1 trial at the NIH Clinical Center, and actually the results were quite good. No prohibitive safety signal, quite good antibody levels, and very good CD8 positive T cell responses. Because of this, we'll be moving ahead in a phase 2-3 trial. Along with that is the VSV made by Newlink Company. Same principle, the insert goes into a VSV carrier or vector instead of a chimp adeno. Again, phase 1 trials done not only here in the clinical center, but also in collaboration together with a variety of groups, including the vaccine studies that we're doing in Mali with Mike Levine from the University of Maryland on the chimp adeno. The pipeline of therapeutics are shown here. I just want to make one comment that although you've heard a lot about these, we need to be careful because none of them have actually been shown in a trial to be effective. They've all been given on compassionate usages. So we really do need clinical trials on this. And finally, there's been the passive transfer of convalescent serum, particularly from Kent Brantley, who has given it to several people. Again, we do not know if this works. And we've got to be careful as scientists and clinical trialists that although we have great compassion for the people who are suffering from this terrible disease, that we've got to be careful that we make sure that we do interventions that we ultimately know that they work before we widely distribute them. And that's what we're trying to do, is balance the compassionate use with the ability to determine if something actually works. So on this last slide, looking ahead, there are 3 things we need to focus on. 1, to continue to keep our eye on the problem, which is West Africa. The best way to help and prevent there being Ebola in the United States or UK or Europe or any other place is to snuff out the epidemic in West Africa. The next is to prepare for future outbreaks. We have a global health security agenda which would give the infrastructure that were in place in Guinea at the time. It is unlikely that we would have had this smoldering of unrecognized disease for several months before the outbreak occurred in earnest in West Africa in March. And then finally, as a nation and as a society, we need to move towards eliminating, to the extent possible, and I know this is not going to be very easy, but to the extent possible, disparities of healthcare infrastructure in the developing world. Because getting back to the title of my talk, The Perfect Storm was several things, but one of them clearly was the fact that there is an extraordinary disparity of the haves and have-nots in healthcare infrastructure in the developing world. And as others have said, freedom from disease and suffering should not be related to where you were born or where you live. Thank you very much.
Tony, thank you very much. How was that? For that outstanding lecture, which is extraordinarily informative. We can take a few questions for Dr. Fauci at this time, and we'll see whether or not he can hear. If not, I will try to transmit it. Dr. Snyderman.
Tony, Ralph Snyderman.
Let me just check. Tony, can you hear?
I can hear you, Al, but you're probably going to have to repeat the person's question. But I can hear you perfectly well.
Tony, this is Ralph Snyderman. Good to see you, although I wish I had been able to see you in person today. But on behalf of so many of your colleagues that have seen you grow up, we're really proud of you and all the wonderful things that you're doing for our nation and the world. Just a general question, and you addressed it at the very end of your talk, and that is looking forward. You have been speaking, at least for the last 10 years, of one of the greatest threats we have as a civilization are these emerging infections that are spreading from parts of the world that we often give very little thought of. So do you see any concrete actions in which we could build off of this enormous fear that we've had into really specifics of doing good here in the United States, building the research infrastructure, and meaningful, tangible changes in how we deal with these issues internationally?
Tony, could you?
I got most of it. Thanks, Al. Well, the fact is that's a great question, and that is what we are really focusing on right now, that all of the things that we are trying to do in our international work has to have as part of it building a sustainable infrastructure. And I think one of the success stories about that have been the PEPFAR program, where we've actually gone in and not only done what you all know what PEPFAR does, but we've left an infrastructure that has actually been important and relevant in responding to other diseases. So what turned out to be an HIV-specific building of a sustainable infrastructure is now being applied to other diseases. So I think you're absolutely correct that, Ralph, that this is what we need to do. In fact, the president announced in February somewhat of an analogous approach, what they're calling the Global Health Security Agenda, which builds sustainable infrastructure. So we really need to do that because we live in a global community, and this is going to happen again and again.
Another question, Dr. Needleman.
I wasn't clear about the diagnostic. Is that a PCR or antibody? And really the question is, how early is it detectable in the plasma, or is there not enough of a viral load to really know in a patient early?
Al, you have to repeat the question because I didn't hear that very well.
That was Phil Needleman asked the question. That is really whether or not there is a detectable viral load. There is undetectable viral load, so that it makes it very difficult to detect the disease in the early stages. Is it a matter of viral load or not? Or what do you use? Do you use PCR or not?
Yeah, it is a matter of viral load because if you look very, very early on, you don't detect it even by the most sensitive PCR at the time the person is starting to feel maybe a little vaguely flu-like. It's when you start to get a symptom that really is a definable concrete symptom, be it fever or something else, that's when you get it, but you get it at a very high cycle rate. So when you get above 40 PCR cycles, then that's it. There's very little, if any, virus. When you get it at 35, there's very, very little, and you might miss it. But when you're full blown, just with 5 to 10 cycles, you can pick it up. So the answer to your question, Phil, is that it purely is a viral load issue.
Thank you. Another question? Yes, Dr. Cullen, head of our Cancer Center.
So when the president visited you at the NIH last month, he put in a special request for additional funding to support the relief effort and research. Was that included in the funding bill that the Congress passed yesterday?
Did you get that?
It was a budget question. I didn't hear it, but I give you the answer because it can only be one. So the NIH and all of the other agencies in the omnibus got if it goes through, got a flat budget. However, The money that the president asked for was new additional money that was not reprogrammed. He asked for $6.18 billion. The ultimate agreement was around $5 billion. The NIH asked for a very, very modest amount, $238 million for vaccines and drugs and other development, but we insisted, and I did personally, that we really didn't want any money if it was going to come out of the NIH's money. It had to be new money. And the president agreed. And it looks like if we get that request, which is less than 6.18 and probably around 5, the NIH will get about 238 million, which is a really small amount compared to the response and infrastructure and other things that have been asked for by other agencies.
We'll take one or two more questions. Any more? Yes, sir.
Just a general question. I mean, why most of the deadly virus they start from Africa? Is it's genetic or weather or hygiene?
The question was why many of the deadly viruses seem to start in some areas in Africa.
Well, I think it relates to what I said in the very early part of my talk, that 75% of the new emerging viruses are really zoonotics that jump species. And because of the density of non-human primate and other species in Africa that have viruses that genetically are more adaptable to their species that are closer to human, it's the same reason why HIV/AIDS emerged in Africa and then went to the rest of the world. And it's the same reason why you see emergence of flu, mostly from Far Eastern countries in which you have the proximity of the fowl that are the primary reservoirs of influenza are in very close proximity to the people in those Far Eastern countries. With Africa, it's just proximity and interdigitation between species. Nothing genetic about Africans, it's just location.
Well, Dr. Fauci, let me thank you on behalf of the Paris School of Medicine faculty and staff and our advisory committee for taking the time to speak to us at this time. It's been an extraordinary keynote address that I can say everyone was delighted to receive at this time. We wish you the best of luck with your meetings today, and we know that the President will be benefited from your counsel.
Thank you very much, Al. It's great being with you. Thanks for allowing me to do it this way. Thank you.